Hello, my name is Kevin Clough. I'm a Drake Pharmacy student currently on an acute care rotation. I'm going to talk to you today about SGLT-2 inhibitors and DKA. We'll be discussing a brief bit of background on the subject, presentation, testing, as well as treatment. Disclaimer, the thoughts and opinions discussed in this presentation are my own and are not affiliated with any professional organization or establishment. DKA, or diabetic ketoacidosis, is a potentially life-threatening emergency that mainly occurs in type 1 diabetics. Common characteristics of DKA include hyperglycemia, metabolic acidosis, and ketonemia. Occasionally, DKA can present without increased blood sugar levels in certain patient populations, such as those taking SGLT-2 inhibitors. This specific type of diabetic ketoacidosis is called euglycemic DKA. For patients with this subtype, they may likely have ketosis and metabolic acidosis, but may be distinguished by less drastic glucose elevations, usually somewhere below 250 milligrams per deciliter. DKA occurs when the cells in your body don't have the glucose that they need for energy. What this tells the body is that it needs to start breaking down fat to use for energy. This process of burning fat creates ketones as a byproduct and is usually initiated when the body does not have enough insulin to use glucose. When ketones accumulate, the blood becomes more acidic and the patient may start feeling sick as a result. SGLT-2 inhibitors work by inhibiting sodium-glucose cotransporter 2 in the paroxysmal convoluted tubules of the kidneys. What this does is prevent reabsorption of sodium and glucose and increases their excretion in urine. Why this process might lead to diabetic ketoacidosis, specifically euglycemic DKA, is thought to be because this increased glucose excretion is keeping our diabetic patients euglycemic, while their insulin deficiency is going to cause ketosis. Your typical patient presenting with DKA would normally be urinating more frequently than normal, feeling very thirsty, fatigued, and maybe even nauseous, and, if able, report some acute weight loss among many other potential symptoms. However, patients taking SGLT-2 inhibitors may not only just present with euglycemia, but they may also be distinguished from a classic DKA patient by other symptoms such as less urination and less thirst. Now, initially, patients suspected of having DKA would have their anion gap, glucose, ketones, electrolytes, arterial or venous blood gas, blood urea nitrogen, creatinine, and CBC with differential all checked. But for patients taking SGLT-2 inhibitors, it is important that a blood sample is used to measure serum ketones. This can be done by either obtaining a blood sample from a vein in the arm and measuring the concentration of acetoacetate in the sample, or by measuring at home from a sample obtained by a finger stick if your glucose monitor is able to check for ketones. It is important to note that patients can use a urine sample to check for ketones, but understand that in patients taking SGLT-2 inhibitors, urine ketone measurements can be misleading. As for treatment, the principles of treating DKA are going to be the same regardless of whether or not the patient is euglycemic. Our goals for treatment are to restore intravascular volume and to correct any electrolyte abnormalities, acidosis, and hyperglycemia if present. Our first-line therapy is intravenous fluids. Administer normal saline at a rate of 1 to 1.5 liters per hour as initial fluid replacement. This is going to help lower the patient's blood glucose, clear ketones, resolve acidosis, and ensure that our patient is adequately perfused. Once the patient's volume status has been stabilized, next is to resolve any electrolyte abnormalities. If the patient is hypokalemic, it is appropriate to replace potassium only after adequate renal function has been established. You can consider replacing magnesium if serum levels fall below 1.2 milligrams per deciliter. However, know that supplementing phosphate is not routinely recommended. After initiating fluid resuscitation and the correction of hypokalemia, intravenous regular insulin is preferred to treat hyperglycemia at a rate of 0.14 units per kilogram per hour as a continuous infusion. Once serum glucose drops below 200 milligrams per deciliter, consider decreasing the rate of insulin administration. Last, but certainly not least, once the patient's hyperglycemia has been addressed, we can then address the underlying cause of DKA. Listed below on this slide are all the references that were utilized in the making of this presentation, and thank you all for watching.